talk with us today. Thank you.
Hello, I'm Julia, and I'm very excited to speak to you all today about Grady's superutilizer population. As Dr. B.C. Jones said, this has a lot to do with social determinants of health, so thinking beyond just what's happening clinically with your patients, but also what's happening in their lives outside of the hospital. So just to get started, as a basic introduction, who are superutilizers? They're a population that exists at the intersection of high cost and excessive healthcare utilization. So it's not necessarily a patient who's coming in with a lot of trauma, who's incurring a lot of costs one time and then leaving. It's patients who are coming back over and over again and incurring repeated costs. They have very complex social needs. So something that characterizes superutilizers are issues like homelessness, substance use, uninsurance status, unemployment, and a lot of mental illness. They also have a lot of structural barriers to healthcare and access to care. They're characterized by receiving fragmented care. So these are patients who are coming in, they have something called ambulatory care sensitive conditions. These are essentially conditions that could be managed in an outpatient setting like diabetes, COPD, pneumonia. However, they're coming to emergent care or inpatient services for this kind of care that actually can be addressed quite routinely in an outpatient setting. And they're very marginalized members of society. I think when we think about, especially at Grady, what are the kind of patient population that you're seeing the people who generally in their life don't hold a lot of power. They're not people who make a lot of money. They don't have stable employment. They're not someone who might earn respect kind of in our society as we've created it. They're people who are pretty much pushed to the side most of the time. So why is it important? Of course it's important from a provider standpoint because these patients are very sick, but we also have to think about healthcare costs, particularly in the context of healthcare reform. So as I'm sure most of us know, healthcare costs are highly skewed. 5% of the population incurs 50% of healthcare costs in the United States. But when we think about superutilizers, we want to dig a little bit deeper, and we want to think about, well, what are the kinds of costs that they're incurring? There are some key factors to the kinds of costs that superutilizers are incurring. So multiple chronic conditions is a huge contributor to excess healthcare spending. So multiple chronic conditions is exactly what it sounds like. It's when a patient has more than one chronic condition. Someone with an NCD has 7 times higher healthcare spending on average than someone with only one chronic condition. They can constitute a disproportionately large share of hospital discharges. So in 2012, it was 70% of 28 million discharges were patients with multiple chronic conditions. And their hospital stays are very expensive. In 2014, it was an average of $14,500 per stay. Hospitalization costs are also very expensive. So in 2011, only 7% of the US population was hospitalized, but that accounted for 1/3 of all healthcare spending, adding up to approximately $375 billion in healthcare expenses, only coming from 7% of this population. And over 60% of that is paid for by Medicare and Medicaid, which is a population also very well represented at Grady. We also want to think about readmission rates and their related costs. So in 2011, there were 3 million 30-day readmissions, accounting for $41 billion. And that readmission rate is very important from a quality perspective because a 30-day readmission rate is a very standard indicator for the quality of care that patients are getting, and something to bear in mind as we kind of look at the results from our study. So what are some of the influencers for specifically hospitalization and readmission rates? Insurance type. So when I say insurance type, I mean that almost as a proxy for social standing. So think about your Medicare, elderly, disabled people, Medicaid, usually lower income. People are getting admitted and readmitted for different reasons. Medicare users typically come in and are admitted and readmitted for congestive heart failure, sepsis, and pneumonia. Medicaid patients come in for issues related to mental illness and substance use. And private payers come in for elective chemotherapy and complications from surgery. So it's already interesting to think about why people are being admitted and readmitted. Private payers are also less likely to be readmitted than Medicare and Medicaid beneficiaries. And then of course there are social factors. So your lower income populations are more likely to be admitted to inpatient services than higher income. They also have longer lengths of stay. And your homeless populations, more acute conditions, more chronic conditions, longer lengths of stay, and smaller recommendation admissions. So I think this idea behind social determinants of health is nicely represented in Anderson's theory of healthcare utilization. This is a framework that he developed in 1967. And essentially what it shows us is that societal determinants, technology, norms, and also policy impact our health system services, specifically hospitals, the resources they have, and how they're organized. And both of those work together to impact individual determinants of healthcare utilization, which then actually is the final result is going into the doctor or being admitted. And today we're going to be focusing on these individual determinants on the patient level. So what are the individual determinants of healthcare utilization according to Anderson? The first are predisposing characteristics, and these are essentially your very base foundational characteristics that impact whether or not someone utilizes healthcare services. They're things like your demographic, your age, your sex, your race. What I thought was very interesting was that he actually points out past illness as a predisposing characteristic, because he argues that if you have a prior illness, you're more likely to continue coming back for healthcare. There's also the social structure, which is essentially different factors that represent your standing within your community and what your immediate community is like around you. And then you have health beliefs. As someone coming from public health and also with studying anthropology, I think it's a really interesting aspect that we don't think about quite often. What do people actually think about being healthy? What do they understand about their illness? Why do they want to seek out healthcare in the first place? And those are really critical factors for health-seeking behaviors. And then we have enabling characteristics, and I think one nice way to sum up enabling characteristics is access. So things that we typically think of when we think of healthcare access. So income, insurance information, do you have a provider close to you that you can get to easily? And then also on the community level, kind of these structural factors. How expensive is it to seek healthcare in your area? How easy is it to get healthcare? Are you living in a very rural area where you have to drive very far? Are you living in an urban area where there might be access to hospitals, but you're living somewhere where it's almost like a food desert, it's almost like a health desert? And then your most proximal determinants are your illness level. And this, I think, particularly from a provider's perspective, is interesting because we have perceived illness versus evaluated illness. So a perceived illness is actually how an individual judges their symptoms and their feelings, and that determines whether or not they decide to seek healthcare. So in the context of this study, what I saw over and over again was we would have people come to the emergency department 70 times, but they would only be admitted 3 times. And then we'd have people coming in 5 times to the emergency department and also being admitted 5 times. So what's the difference in how they're understanding and perceiving their own symptoms of illness, and how is that driving their behavior to come to the emergency department? So, the research goals of my thesis, there were 3 primary research goals. The first was just to understand who are Grady's superutilizers. What are their characteristics? The second goal was to quantify the contributions of medical and social factors to their odds of becoming a superutilizer. Again, we're trying to think beyond just what's going on with diagnoses and physiological factors, what are the social barriers that exist. And lastly, does a superutilizer increase your odds of mortality? So just quickly go over my methods. This was a case control design. The population, we had 247 high utilizer patients, and I'm just going to walk you through how we defined that. So we essentially pulled a master list of patients who were admitted to inpatient services from the emergency department. We looked at the 95th percentile and the 95th percentile. At the 95th percentile, it's 3 admissions in a calendar year, and there were 3,000 patients in that population. The 99th percentile was 5 admissions per year, and there were approximately 700 in that population. We did a simple random sample of the 95th percentile, which provided us with, we did approximately 250 patients. The reason we have 247 is because we excluded patients who were being admitted for dialysis from the emergency department, because it's a slightly different population than what we're generally interested in. We then matched controls. We pulled 247 people who had been admitted to Grady only once or twice, and we matched on age and sex. Our data collection was a chart abstraction process. Dr. Sarah Turbo was a huge help with this. I have to commend her. I do not have a clinical background, and medical charts have a lot of information that I don't know. So she pulled all of the information related to clinical diagnoses and all the information related to demographics, social history, intake data, discharge data. And this is just, I'm sorry, it's so fuzzy. This is a way to give you an example of what the data collection tools look like. So this is the diagnostic field. We have the number of admissions. This person was admitted 3 times. And then we essentially created about 12 different diagnoses that we were expecting to see constantly. So COPD, cancer, asthma, diabetes. And then we had, there's 10 free text diagnostic fields. Some people filled up many check boxes in all 10. This is done through a lady, only had 4 additional diagnoses. To give you an idea of how that works statistically, because of statistical power issues, we didn't treat every diagnosis individually. I'll get into what we did in a minute, but just bear that in mind. What were our methods for analysis? So we were interested in a few different buckets of covariates. We wanted to know their demographics, their insurance status and who their payers were, their social histories, and their diagnoses. We put these covariates into 2 different statistical models. We used multiple logistic regressions and pseudo R-squares. R-squares are essentially values that give you a quantifiable way of explaining how much of my outcome is due to these covariates that I put in. So how much can we explain based on what we know? And we had 2 primary outcomes of interest. We had HUC status, high equalizer patient status, which was defined as 3 or more admissions in a calendar year. And we also had known mortality. This idea behind known mortality is key. We only said someone was deceased if they died at Grady and it was in their EMR, or if they were discharged to a hospice in their year of high use. So if they were discharged to hospice in a subsequent year, or if they died not at Grady, we don't know. So this is actually a more conservative way of looking at mortality. So what were our descriptive characteristics from our first research goal? What do our superutilizers actually look like? So I thought this would be an easy way for them to think about, well, what do we know about everything that happens before they're admitted to inpatient service? What does their hospital stay actually look like? And then what happens after their discharge? So, pre-admission characteristics. Basic look at demographics. Age, approximately middle age, more or less half and half male and female. Again, these were matched for cases and controls. Predominantly Black, which probably isn't very surprising, just generally given Grady status in the public hospital. What we did, we collected zip code data, and we used census tract data to get an idea of patients' income, because that wasn't something that we had access to in their charts. So we used median level community income based on zip code data. And one thing that I thought was very interesting and wanted to point out is that over 1/3 of cases of superutilizers are living at or below the federal poverty line for a family of 4. So when we're thinking about social obstacles, 1 in 3 of these patients are coming from probably a very challenging social situation. What was their insurance status? So this was surprising. More superutilizers were insured than just basic controls. We don't really know why. So there's this idea of moral hazard. If you have health insurance, you're more likely to use it. Maybe they have their PCP at Grady, so they're more likely to come to Grady. Maybe the controls are coming from a trauma situation and they're being transferred to Grady. I was thinking about the health insurance status. So we can't really explain that. And then we look at, of the insured population, how does that break down? Again, thinking about poverty, half have Medicaid. Again, we're using that kind of as a proxy for what their social status is like. And nearly 30% of controls are privately insured, typically are privately insured through employee-provided health insurance. Or thinking about marital status, maybe you're married to someone and you're on your insurance. So thinking just beyond, well, what are these numbers telling me? What does it actually represent from this patient coming into my hospital? What's their life like outside of the hospital? We collected information about alcohol, tobacco, and drug use. Across the board, you can see use is much more prevalent in cases versus their controls. Particularly if you look at any street of substance use, we have more than 1/3 using drugs defined as marijuana, crack cocaine, methamphetamines, heroin, basically street drugs. And what are some additional social barriers we're experiencing? Well, nearly 20% are homeless. 71% are unemployed, 12%, more than 1 in 10, have a history of incarceration. And I just want to really impress on you, this is only what we know from the medical chart. experiencing are probably even greater than what we can capture here. And how often are they coming to the emergency department? 247 cases, were in the emergency department over 2,000 times in one calendar year. So on average, they're coming in about 8 times per year. Controls are only coming in just under 2 times per year. So that goes back to this idea of health seeking behavior and health beliefs and how they're perceiving their illness. We had some patients coming 82 times in 1 year, and they weren't coming in for dialysis. So, what was it like when they were actually in the hospital? I'll start with diagnoses. So what we did for the diagnoses, we didn't use ICD-9 or 10 codes because they have the tendency to lose a little bit of nuance in your analysis, and we couldn't keep the diagnoses individual because of statistical power, so we combined them into organ buckets essentially. So all cardiac conditions, hematological conditions, pulmonary conditions, endocrine. Most of these are, for example, endocrine, mostly diabetes. But people were able to have more than just one. So you can see 83% of cases have some kind of cardiac condition, at least one. I think it's very interesting that 62% of controls also have cardiac condition, so even though that's still a lot. A lot of hematological conditions, mostly anemia, by and large. Also, some cancers, but anemia was a really big driver of that big difference. Endocrine, mostly diabetes, 45% prevalent rate, 4 times the national average, which is currently 12%. Psychiatric conditions, like we said, superutilizers or marginalized members of society. Medicaid superutilizers get reasoned a lot for mood disorders. We're seeing that represented in our sample. Twice as many cases as controls have psychiatric conditions. 1/4 have a form of infectious disease, which mostly includes HIV, AIDS, and opportunistic infections. And slightly more controls than cases had trauma, which we are chalking up to the fact that Grady is a level 1 trauma zone. Medicinal utilization measures. We wanted to know about length of stay and time to readmission, so essentially when you're discharged, how fast are you coming back? We have mean and median. We'll talk about median because we had some pretty big outliers that we're seeing in our data, but there isn't a big difference. Cases and controls are in the hospital for the same amount of time, and thinking about that 30-day readmission rate as a quality indicator, cases and controls are both being readmitted at or slightly less than 30 days. And then we have total hospital admissions. 247 cases were admitted slightly over 1,100 times in a calendar year. Controls being admitted 305 times, so almost a 4-fold difference. Going back to this idea of cost and patients with multiple chronic conditions, as we've seen many of our patients have, at a rough average of $14,500 per stay, the estimated cost of these superutilizers is approximately $16.3 million just in 1 year. If 1/3 of them or 30% of them are uninsured, those are uncompensated costs in the realm of about $4.5 million. And then we want to know about their post-stay characteristics. I'm going really fast. Where are they being discharged to? How many outpatient medications they have? And lastly, we want to know about the STEM mortality. So overall, cases far less likely just to be discharged to home care. Many going into nursing homes, specifically rescue, is very common. And 3 times as many cases as controls are being discharged to hospice, typically for cancer, HIV, AIDS, some end-stage COPD. And then we counted outpatient medications, so excluded any medications the patients were administered during their inpatient stay. 247 cases had 4,500 outpatient medications in 1 year. This is not the cumulative number of medications in their EMR. It's just for that one specific year. So they're taking about 18 outpatient medications when they're not in the hospital. Thinking about utilization and thinking about, right now we're talking about inpatient service admissions, and that's the idea of this, but you can really see from all of this that utilization, you're not super utilizing just in one area. You're probably going to the emergency department all the time. You're on a lot of different medications. You're being admitted a lot. This is not just one more specific area. Your patients are utilizing in so many different ways. And then our controls, again, far less outpatient medication. I don't think that's for you. And then lastly, we wanted to know about known mortality. So about 1/4 of patients of superutilizers died that we know of over a very short-term follow-up. So we finished our data collection in February of 2015. So the earliest a patient could have been admitted was in 2011 or up to 2013. So we're talking maybe about a 3 to 4 year follow-up. We know that about 23 to 24% of people died. We know that that's a conservative estimate. I would make an educated guess to say it's closer to 25 to 30% of patients are dying. And just to highlight again, we know that controls are coming in more with trauma. So think about the reasons that these patients are dying as well. So we ran multiple logistic regressions to determine these two outcomes of interest. What are the social and medical factors that contribute to being a high utilizer patient, and is being a high utilizer patient make you more likely to die over short-term follow-up? So this chart essentially just shows the different odds ratios of the 13 factors that were statistically significant and 95% confidence level to being a high utilizer patient. And right off the bat, in the first top 5, 3 of them are social factors. Medicare, that's a proxy for age or disability. Medicaid, we know that that's poverty. And uninsured, we know that's unemployment or poverty. A combination of the two, essentially. And the fact that just in our top 5, we can see social factors are playing such a role. I mean, if you have Medicare, you're more than 5 times more likely to become a high utilizer patient. That's very profound and very significant when you think about your patient interactions. You have these patients coming to you, they're coming from incredibly difficult social situations, and there's something that's driving them to continue to come back into the hospital. And it's not just their diagnoses, it's not just what's going on physically with them. Homelessness, almost 3 times the odds of becoming high utilizer patients. History of substance use, higher than endocrine. Even though 4 times the national average is represented for diabetes, it still matters more if you have a history of substance use or homelessness. So just thinking about these social determinants of health, how can we keep patients healthy? How can we ultimately keep them out of the hospital? We have to think just beyond the number of medications that we give them or how we treat them. And then we also looked at our mortality model. So these are the results from our fully adjusted logistic regression, which means that all of the demographic, social, diagnostic, all the descriptive characteristics that I showed you are in this fully adjusted model. Being a high utilizer patient is still the most significant predictor of short-term mortality over having a cardiac condition, over having a stroke, or coming in from a car accident. It's just the number of times that you're admitted. If you're in the hospital 3 times or more, your odds are twice as high as dying as someone who's in there less than 1. So, what comes next? I think that this is a topic, as a public health practitioner, I'm putting myself in your shoes, as a physician, this is very depressing to see because you are dealing with patients who are coming in with an overwhelming amount of problems, they're coming in over and over again, and they're dying. Well, so what can you actually do, and what are the implications for this kind of work on a policy level, on a health systems level, and on a provider level? So there are some pretty significant policy implications behind this, especially considering the Affordable Care Act and healthcare reform. So the Affordable Care Act, I'll discuss 2 key things that it's doing. It's really changing the way that we deliver healthcare for you all as physicians, especially physicians, those of you who are starting your career. This kind of work is going to actually change the way that you interact with your patients and change your work as a practitioner. Innovative care delivery is being rewarded by the Center for Medicare Services. It's being rewarded by the Affordable Care Act. They are really paying attention to these super utilizers who are eating up a huge amount of healthcare costs, who have preventable problems if we can just figure out a way to help them. And the second big thing that's happening with healthcare reform is this idea that Medicare is moving from fee-for-service to fee-for-quality. And again, has a lot of implications for your careers as physicians and for our career as public health practitioners. So fee-for-service is essentially what Medicare has been operating under. It's that it pays for a lot of volume. It's not necessarily very patient-centered. And now it's moving to this idea of fee for quality, and it's really focusing on outcomes data. So thinking about the outcomes data we spoke of here, specifically readmission rates and mortality. Those are two key things that are impacting how Medicare reimburses their providers. And just to go back to this idea of innovative care delivery, I'm sure many of you have heard of accountable care organizations and patient-centered medical homes. That's essentially the future of what healthcare delivery is going to be like, because it's a way of addressing all the complex needs that patients have that exist outside the realm of the hospital and that they bring with them when they're living. And then lastly, just the idea that the health marketplace is changing and health services research is changing. This is a topic that we've started to hear more and more about. October Monday wrote a piece in the New Yorker in 2011 called The Hotspotters, which started to draw a lot of attention to this topic. I mean, the amount of research that's coming, it's growing exponentially. This is really the future of where healthcare services research is going. So something to think about as your careers. So what are health systems implications for public hospitals like Grady? So Grady is like a public hospital. Only 2% of hospitals are public hospitals, and they account for 25% of uncompensated care in the United States. That's already a major consideration. Think back just to this subsample of our population. We know that 30% don't have any insurance, are driving in several $1 million of uncompensated care per year. It's very important. As you know, payment systems at Grady rely primarily on Medicare and Medicaid. They also rely on county funding from Fulton and DeKalb. One thing I found very interesting when I was doing this research is that our super utilizers are predominantly from Fulton and DeKalb. We have people coming in from trauma, for trauma conditions, from, gosh, what are the other counties? Henry County, Fayette County. These are really expensive patients, but none of their counties are contributing any money to Grady's fiscal financial health. Which brings us to Medicaid expansion in Georgia. So, as you know, Georgia has chosen not to expand Medicaid as of yet. When I was doing this research, I knew about Medicaid expansion. What I didn't know about was this idea of disproportionate share hospital-adjusted payments. These are essentially federal payments that the government makes to hospitals to take on an undue amount of uncompensated care. And they're cutting payments that they make in half because of Medicaid expansion. So by 2018, Grady will have approximately $45 million in cuts, guaranteed. And the idea was that the states would expand Medicaid, and that the burden of those fiscal cuts would be lessened by the fact that we have more patients coming in who are insured. I think, again, when we think about Medicaid, we think about it from the individual access and how important it is that people have health insurance. We also have to think about it from the health system's perspective. We need cash. We need that cash injection. It's so important. It's so important to advocate for Medicaid expansion in Georgia, not only for the health of our patients, but so that places like Grady don't suffer financially and can actually continue to provide care to the patients who need it the most. But there are opportunities for intervention and innovation, and those are coordinated care centers, among others. But today I'll be talking specifically about these coordinated care centers. And the idea behind coordinated patient care is that the patient isn't the only person managing their care. They have someone from a health system helping them out. It might be a nurse practitioner, it might be a social worker, it could be a pharmacist. It's essentially however the organization decides to structure that. The idea is that the patient isn't completely on their own when it comes to keeping themselves healthy. So some of the things that coordinated care centers do, they work on active case management, they promote patient self-management, they have patient education components and community outreach. So I'll give 3 different examples of some successful coordinated care interventions that have some very interesting results. So Hennepin Healthcare is a public hospital system in Minneapolis, Minnesota. They implemented a coordinated care center. They essentially made it a one-stop shop. There are physicians, there are social workers, there are pharmacists, there are substance abuse counselors, all working together with patients that they have identified as super utilizers who have these social barriers that we've talked about. Again, homelessness is a major contributor. And essentially tried to make it so that the patient wasn't completely on their own. After 1 year, the hospital was able to decrease their total charges by 23%, so about $25,000 per patient, and they decreased ED visits by 37% and inpatient stays by 25%. Something else that they did, which I thought was very interesting, was that they noticed that they had a very large share of homeless patients. They decided to secure stable housing for the patients because it was cheaper for them to do that than it was to continue admitting them. So when we think about innovation and what we can do, and how much control do we really have as providers or as health systems, maybe more than we realize. Cleveland Metro Health is another organization that did a coordinated care intervention. They targeted their high-cost, high-utilizer Medicaid patients specifically, and they focus on their medical needs and their social barriers to health. Same thing that I've been repeating over and over again. They decreased ED visits from that population by 39% in 1 year. And just continue to have this idea about cost in the back of your mind and the implications for patient health and for cost. Lastly, there's a Camden Coalition of Healthcare Providers, which was spoken about a lot in the Children One Day's Hotspotters article. They're pretty much the preeminent organization that's running programs specifically targeted super utilizers. They only targeted 37 patients in their first year. They were able to decrease hospital bills by about 40%. A combined monthly total went from $1.2 million to slightly over $500,000 per month. And then what are the implications for you all as providers? I think that there are a lot of things that are out of your control. As public health practitioners, out of our control. How can we influence the things that patients do when they leave the hospital or they leave the clinic that keeps them from coming back? You know, you can't just take the cigarette out of their hand necessarily. What do you do? And that brings the idea of this thinking beyond the diagnosis. These super utilizer patients, they exist at the intersection of physicians and social workers. They don't just sort of exist in one silo or another. So what does it mean for you all as a provider? It means thinking beyond this patient is coming to me with COPD. It's thinking, well, what else is going on in their life? Maybe I ask a few more questions. The chart extraction process is not an enjoyable process. The ones that were most enjoyable, relatively speaking, were the ones that had these long, beautiful social histories where they just, you could tell they really sat down with their patients. They really tried to find out, you know, what's the root cause? Why do you keep coming back? And that brings me to this idea of collaboration. So for providers, how can we think about operating in cooperation and collaboration with all of the different healthcare providers, including social workers in our health system, and not only working in silos? I think there are some really great examples of how Emory does that. And then lastly, shifting healthcare policies, going back to this idea of Medicare moving from fee for service to fee for quality. That's going to impact your career very profoundly. And how do you think about how to bring this policy and its meaning into your work as a provider? This is a really difficult thing, something I really struggle to talk about because I'm not a physician. I don't really know what it's like. And I'm not saying that people don't do this, but I think sometimes, speaking from personal experience, it gets really easy to get caught up in the day-to-day and just to try to get through the end of the day and get home. But sometimes it's also really good just to take a step back and think a little bit bigger picture. So just to go over the strengths and limitations of the study, because there were certainly both. Strengths of the study, it was a public hospital. A lot of the studies took place in academic medical centers or private hospitals where the population is a little bit different and you don't have access to homeless patients, to people who are coming from jails. We looked at non-clinical factors. Many of the different research studies that I was reading and the risk scores that I was reading didn't take into account social factors like homelessness, substance use. They would look at patients who specifically had congestive heart failure or COPD, and maybe it was because they didn't have access to that kind of information, maybe because at the time the research wasn't focusing on it as much, but certainly a strength of the study. And the disease classification system, just as I mentioned, being able to kind of combine things broadly from a statistical power standpoint and also not getting too caught up in the nuance that ICD-9 codes introduce. Limitations. was just a single hospital study, I think especially considering what we know about our cases and our controls, it's totally likely that there were cases who were admitted once at Grady and 3 times at South Fulton, and they're superutilized somewhere else. We don't know that because we don't have access to that information. And it's just as likely that our cases are actually being limited just as much to other different hospitals. So they're actually overutilizing even more than we already know. It was a retrospective design. It's always a limitation in this kind of study, especially with the data quality, because we're not collecting it ourselves, we're relying on what's already there. And if it's not being collected with the idea of research in mind, sometimes we run into some problems. And lastly, generalizability. That pertains really to the statistical models because we're not using ICD-9 codes or we're not using a standardized way of looking at social and medical obstacles. We can't actually reproduce this in a different setting without going back and reworking the model significantly. But there are some very interesting future research opportunities. So the first is this risk score I mentioned. We want to actually be able to prospectively identify the people that are coming in. We want to be able to create a statistical model that assigns quantifiable weights to different exposures, social and medical, that allows us to determine who is a social superutilizer, who we haven't caught yet, or who's going to be a superutilizer. And that's why we need that prospective design. This idea of a social survey, essentially doing a blinded survey of people who are currently on an inpatient service, people who we know are high utilizers, and people who have only been admitted once, so we can get deeper into social issues so that we can know what's their highest level of education, what's their individual income, are they married, what's their social support like, do they have access to a car, really things that, again, contribute to why they're actually in the hospital. And lastly, qualitative data. Qualitative data is sometimes overlooked in research, but it really gives us the opportunity to dig into what the patient experiences are like, identify some things that we maybe haven't thought of or we need to redirect our research, or show us that our research is on the right path. So, I've been talking for a very long time. I've said a lot of things that are very depressing. So I want to leave you with 3 concluding remarks. The first is just reiterating what I've been saying this entire time. Go beyond the clinical when you think about your interactions with your patients. Think about what we know is contributing to their odds of being these high-use patients. If you have someone coming to you who is homeless, who is uninsured, and has a history of substance abuse, take them to the social worker. Bring the social worker in. Find a way to really identify that person, knowing that just those 3 factors are already increasing their odds that you're going to see them again. Think about Medicaid expansion in Georgia. Go to the Capitol, advocate for Medicaid expansion. Think about how integral it is to the health of Grady as a health system and to the health of your patients. And lastly, there's this idea of your locus of control. I moved to Atlanta in 2010 to do Teach for America, and something they told us over and over again was find your locus of control so that you don't lose your mind, essentially. And I had no idea what they were talking about. And the idea is very similar to the experiences that you have with your patients coming in and having all these problems. My 8-year-old third graders would come in and they wouldn't have dinner the night before, or they would be in abusive parental status, and would think, well, God, there are so many different things going on with my students. I only have them for 8 hours of the day. I can't go home with them. What can I actually do? One thing that Teach for America challenged us to do was be creative about how much you can actually control. So I had a student who was very sweet and very bright and tried very hard, but was starting to struggle academically, and I wasn't completely sure what was going on. As it turned out, he couldn't see, and his mother didn't know where to take him to get his eyeglasses and couldn't afford it. And I can't leave my classroom and take him to an eye doctor and pay for his eyeglasses, but what I was able to do was go online and find a free vision clinic where he'd be able to get glasses and send that information home with his mother. So just find what you can control, think outside of the box a little bit, and see how you can keep your patients from continually coming back. So acknowledgements, I'd like to acknowledge Dr. Maura George and Dr. Sarah Turbo. So integral to this work. I'm so thankful that they allowed me to be a part of this as just a lowly master student. A very special thanks to my thesis advisor, Dr. Mo Ali. Truly couldn't have done this without him, and the entire team at Grady Emory for just being a really great support system. Questions?
question is, from like the research perspective at least, what do you wish was in the chart that wasn't? Like either as a searchable function, like I know like age is really easy to search, so like either in that kind of top level searchable function or from our end in the charts and the social history.
So that's a great question. One issue that we had pretty routinely was there wouldn't be a social history. And they would say, updated in a different part of the patient's chart or same as last time, but it wasn't very trustworthy information. So one thing that I would have loved to see was if your patient wasn't using anything, not just to leave a blank, because we actually treated no mention of use as a non-use. Because after speaking with a different clinician, we assume that if they're using something or if it shows up in the test and they admit it, you're going to put it in the chart. If it's not in the chart, we're making an assumption that they're not using. So consistent data on that. Also, it's my personal bias, but education information. I think that can give us some really valuable information because it also goes into this idea of health literacy. How much does the patient really understand about what's going on with them? What kind of follow-up care they're doing?
That was a really great talk. I want to get your thoughts about healthcare payment changes, and so in the future, even now, they're talking about carrots versus sticks, and so Grady had to, for example, pay back about $800,000 this year for readmission rates, and we have a underserved patient population, and managing this population might be different from other hospitals, and what your thoughts are about that. So the emphasis is on quality and outcomes, but there's a bit more challenges around taking care of certain populations of patients.
Right. That was something that I spoke to Dr. Ali about when I was preparing this presentation and how private insurance companies are incentivizing their patients, their beneficiaries to practice good health care, but Medicare and Medicaid haven't really followed that yet. So I think part of it is a policy piece of whether or not Medicare and Medicaid are going to help encourage that kind of behavior. The other piece I think is the healthcare exchanges and how that individual health marketplace is working. Patients are going to start seeing that they will have higher premiums the sicker they are. So maybe that's kind of a way on an individual level for an insurance company to motivate them. In terms of what as a health system you can do, I'm not completely sure what it's going to do.
That's great. Thank you.
Yeah.
I'm curious about what percentage of superutilizers are admitted for mental health reasons, and how much do those hospitalizations cost compared to medical?
So we do not look specifically at what percent are being admitted for what different reasons. In terms of cost, so patients with multiple chronic conditions have this inpatient cost of about $14,000 per stay. Regular inpatient costs are about $10,000 per stay and rising. So I would say that since it's an inpatient, probably in the $10,000 to $11,000 range. I can't say for sure though.
So, but like, what you don't know, like, what percentage of superutilizers are just coming first, like being there for psych reasons?
We could, but it wasn't part of this research. We have the data, but it's just not good function. Yeah.
Very nice talk. One thing that's interesting is the fairly high mortality rate. I know it's also been seen in similar populations, but mortality might also be a surrogate for severity of illness.
Yes.
If you remove the people that died from your analysis, does it change the factors?
We actually didn't
In other
do
words,
that.
people might be really sick and therefore they're coming to the ER a lot.
Yeah, no, absolutely. We've not looked at that. I think that that's a very interesting question. Especially if there's a way, there's the carcinoid comorbidity index, so kind of a way of measuring.
I mean, you might find that it would even further elevate the social factors as a cause of frequent visits.
That's a good point. Yes.
Is there anything in this subpopulation of super users that indicates like what proportion of them might have been having a lot of chronic conditions or medical conditions, and because of that, now they're in poverty due to the costs associated with that, versus the people who were first in poverty and then have social determinants on those?
I mean, I think that's a great point. We don't know directionality, but considering that most bankruptcies in the United States are due to medical reasons, I would say that